So what are the applications to practice? You have to love this picture. It's like the story is in us. And it's in everyone. And part of our job as occupational therapists, one of the things that distinguishes us from any of our colleagues is looking for the story, looking for the meaning, finding the meaningfulness, empowering a person to continue to generate their narrative, to not feel that their narrative is ended or that they can't have a narrative that they might actually value and find meaning in. So the big question always is it worth the time and effort? It can sound, like a lot of time. So let's examine that for just a minute. Mattingly and Lawler tell us for those with disabilities, storytelling may offer its own kind of healing. And so when we frame it like that, I think we can reframe the question we started this slide with is how can it not be worth the time and effort? How can we afford to neglect it? And then Clark quotes Palmer, who says every way of knowing tends to become a way of living. So we come to knowing through narrative, and we move forward in living through narrative. And so we can begin to see how very interwoven all of this is and how we really can't separate it out, and we really don't want to walk away from the story. That we wouldn't be occupational therapists if we did that. And then Clark directly tackles this issue of expediency that we're always forced to address in our practice. And she says occupational therapists cannot be expected to do detailed and time-consuming ethnographies in the clinic, but they can make occupational storytelling and occupational story making the core of their clinical reasoning as a way to nurture the human spirit to act. And I think she's right on here. And I also believe that we do this, and we probably can all fully develop this skill so that we're even better at it, more intentional with it, and we don't experience the push and pull that Mattingly and Lawler talk about later in terms of kind of feeling that we have to walk away from working within drama and narrative. We need to embrace it. So in the next step, what I've done is I've tried to conceptualize how narrative in treatment might work. And the way I did this is by giving us two models to look at. First is narrative in treatment, a transactional model, where these gears, the movement of one affects the movement of another. So we would begin down here in assessment, and this is where we're eliciting the story. We're doing our occupational profile. We might even be gathering objective data while we're doing this, but become very skilled at getting the story, and we become more and more cognizant of the occupational storytelling. Then in treatment phase 1, we may be ready to move on to occupational story making. So you're a new spinal cord injured person, and there are things that feel threatening or endangering to you, and so let's talk about what it's going to look like. Let's create a story, and then let's enact it, which would move us to phase 2. So part of enacting the story would be moving towards new levels of function, desired levels of function, meaningful levels of function in ADLs and IADLs, and finding occupational justice if in fact it's not already present. So that's a transactional model. Let's look at a hierarchical model. Some people might be more comfortable with that. So you would start at the bottom with your problem list, what Clark would call problematiques. How can I get dressed if I'm paralyzed? How can I talk to my friends when I don't know who I am anymore? How can I eat with my family when I can't even pick up a fork? And then we go into clinical reasoning, and we can clinically reason through occupational storytelling and occupational story making. And in this hierarchy, I'm noticing these should really connect together. 1, 2, and 3 would be equal, and they would be moving up into occupational storytelling and occupational story making, and these two would be happening at the same level. They would then come together for occupational performance in the context of ADLs, IADLs and perhaps even occupational justice. So take that for what it is. I'm just offering it as another way for those among us who might be more visually oriented than auditorily oriented. This is just a way to imagine applying this as we're working in the clinic. So since we're going there, we need to talk about why it's so important. I love this in Mattingly and Lawler's 2001 article, The Fragility of Healing, recognizing the uneventful as eventful when they're speaking of Dr. Sachs' experience with his leg. I don't know if you've read anything by Oliver Sacks. He wrote The Man Who Mistook His Wife for a Hat and a couple other books. He's very interesting to read. He's a neurologist, I believe. So he's having this whole eventful experience around his leg, which is actually documented probably by a physician from the sounds of the story as an uneventful recovery. Well, in the medical model, an uneventful recovery is a good thing. Things are going along as they are. There are no untoward events that are requiring an undue amount of attention. Things are moving right along perfectly. Sachs is appalled at this, even as a physician himself. This is anything but uneventful. He is having an experience, and I've highlighted an. They highlighted an in their original text with italics, and then I further highlighted it with color. An experience, we could highlight this whole little phrase, as a thing. An experience. It can be distinguished from other things, from other objects. That can be partly disclosed in a story, in a textual form. So then they also mentioned the centrality of recovery events to healing. So if we accept the idea that these events, the event that Dr. Sachs experienced, are central to healing, then once again we can't afford to not hear the story, to not become a part of the story. So here are some ways that I thought about it in terms of things that I've learned to do or learned through reading or continuing education about approach to therapy. And one of those things has to do with passive range of motion for the person who is comatose or semi-comatose or minimally responsive. And the idea that people, when they've fully recovered, say after stroke, in some of the books that I've read, some of the narratives that I've read, first-person narratives of disability, have talked about how much more powerful and meaningful something as simple as range of motion was for them when the person narrated the experience. This is your right arm. I'm moving your right arm up. Your right hand is touching your head and your hair and your face. I'm bringing your arm down. People report that they could actually feel themselves gaining or regaining an understanding of how this injured body part was a part of them and to begin to reintegrate it. So it's far better, that would suggest, to narrate the passive range of motion of a hemiparetic extremity than to move it in silence. So which way do you want to go? If you believe in the centrality of recovery events to healing, and you believe in the power of first-person narratives, it would be hard to argue with the idea that we should be narrating something as simple as passive range of motion for some of our clients. And then we can look at dressing. Is it better for us to talk to our patients about some techniques that they might use to dress themselves in order to, let's say, save energy because they have multiple sclerosis? Or will they, in fact, learn it better, internalize it, be more likely to follow through on it if they practice that activity, if they narrate it with you, if you create a story about how it can happen, and then you work together to enact the story. And then finally, another example might be a therapy session that is mutually shared, is mutually active, qualitatively exceeds a therapy session done. So we probably have all experienced this as therapists. I mean, I'll admit it, in my 30 years, there have been times when I've walked out of a therapy session knowing that I did therapy, but we did not do therapy together, and it wasn't as good as it could have been and should have been. So, and there are a lot of things that make that happen. I'm not saying that we can accomplish this 100% of the time. I am saying that that should be our goal. Maybe I should say we can accomplish it 100% of the time. You can tell me what you think when we're on discussion board. So that brings us to an end or a beginning if we're going to let the stories begin. So just a couple of final thoughts. We see the baby alligators encouraging Grandpa to tell him about the time that he almost had Tarzan for lunch. So narratives, there's that connection, a passing on of history, a relatedness that's so important in therapeutic relationships. But then I also have the story of the dandelion, and there's a lot in this story. We could all probably come up with a narrative and have a lot of similarities within it without any words. This, to me, is a really important point. Our patients who are nonverbal, for whatever reason and for however long, still have narrative. Narrative does not have to be the spoken word. And for some people, it can't be the spoken word. And their story is still so valid and so important and so powerful. And maybe even more powerful because they need help to get their story out. So I think while we're talking about narrative and we use the words text and story making and storytelling, words that really conjure up images of the voice, that we should think about the nonverbal voice and how much of communication is nonverbal, how important it is for us to be able to pick up on nonverbal cues. We've talked about that a little bit in our relationships with each other, how some of us are feeling a missing dimension because we don't get to see each other. So narrative in the nonverbal person is something I would encourage all of us to keep in mind as well. So that concludes this little introduction to Module 8. Questions are posted on, or will be soon posted on, Google Groups, and I look forward to having a fantastic week of discussions with all of you. Take care. Bye-bye.